I'm in not good shape. I used to be a chopper. I love the bush. I can't even walk around in the bush.
Patrick Deranger is over 6 feet. He exudes authority and wisdom. He loves to spend time on the land. Before his health problems, he was strong and capable.
I have serious respiratory TB when I was 3 years old. A lot of lung damage. I use my machine right here and to breathe.
Like many who suffered from the disease, it left a lasting legacy.
He has respiratory illness that he's been diagnosed as asthmatic, but he also has a condition called bronchiectasis, which is really difficult to get. It's a fairly rare lung disease, and one of the best ways to get it is to have tuberculosis when you're quite young, which he did.
And then he seemed as light as a plastic bag drifting by on a windy day. Patrick lost weight, a lot of weight. In his already weak lungs, he developed an infection. And if that wasn't enough, Patrick needed dental work. A lot of it. He was waiting. He was sick, and the dental problems may have made things worse.
To get them to pay it.
Health problems and red tape kept him from getting the care he needed. Dr. Bilodeau is Patrick's dentist.
That the barriers to that, to getting coverage for treatment for people have been getting, a lot worse, and it is a lot of bureaucracy.
Lee says that they won't even pay to finish work that has started.
When he had the 2 root canals that started the problems, they put the temporary crowns on, and they don't. I don't understand this. They pay for the root canal, but they will, the first step of the process, but they will not pay for the crown to finish the process.
The infection would not clear up. ER visits became routine for Patrick.
We had the ambulance here. They took you in 6 times by ambulance that winter. And he was admitted to hospital. Every year he was admitted to hospital like at least 2-3 times, sometimes 4, for a week at a time.
Lee says she worried constantly, especially at night.
I would lay there and listen to him breathing, and I could sometimes gauge that, no, don't go to sleep because this is getting bad. And within an hour, I'd be calling an ambulance. We were both terrified. 2 years ago, we were both terrified. He was being hospitalized more and more frequently for longer periods of time. This chronic recurring lung infection that they could not clear up, and they were using the strongest antibiotics available, and it wasn't clearing it up.
Like many Indigenous people in Canada, Patrick relies on Health Canada's Non-Insured Health Benefits program, nicknamed NIHB. I tried to make sense of the program by flowcharting it. It covers 6 main areas not covered by the provinces. They are dental, vision care, medical supplies, drugs, mental health services, and medical transportation.
There's often pushback from Ottawa when it comes to certain types of diagnoses.
I met Dr. Alika LaFontaine at a medical conference in Edmonton. He says that what NIHB offers is wanted and needed by all Canadians, not just First Nations.
We have NIHB, which covers dental and drugs. These are things that Canadians are asking for now. There's a national movement for a national pharmacare program. There's a national movement to get dental care included under our public system of health. These are all things that First Nations, saw looking forward that would be necessary.
First Nations are provided these services because of promises made years ago. So is healthcare a treaty right?
Yeah, it's a treaty right. Of course it's a treaty right.
And what do health professionals think? Suzanne Geddes is a mental health worker in Barren Lands First Nation.
Yes, definitely. definitely.
And Dr. McCollum, a dentist from that same community.
Health is a treaty right.
Dr. LaFontaine, team leader with the Indigenous Health Alliance.
So absolutely, health is a treaty right, but treaty is about all treaty partners.
And John Clark, chief of the Barren Lands First Nation.
I think so. It should be, anyway. Yeah.
And what does Jane Philpott, the health minister of the current government, think?
We respect all treaty rights, including rights to health.
It may be a right, but there are obstacles to access that are rooted in Canada's colonial history.
You know, it's a combination of the colonization, it's residential school, because when we went, we were told not to challenge. It was yes, sister, no, sister. No communication.
The system creates layers of problems for residential school survivors like Patrick.
From the time you wake up and the time you go to bed, they tell you what to do, what to say, what not to do. We didn't talk back.
He says the school taught him about white supremacy.
We were told that white people know everything, what's better for us. So we don't question anything. I'm like that still today.
Patrick, like many residential school survivors, did not challenge what doctors and health professionals told him.
If they said no, fine. And I knew, like, when I said that it's my death certificate.
Fortunately, he has his wife Lee to step in and help him out.
It would be about 2 years ago now that he had received yet another no, and he said, I give up. And I went, okay, because he's always dealt with his own stuff. And at that point I said, let me take the battle over for you.
Lee says she was the one who made the connection between oral care and lung health.
Dental issues impact a lot of other chronic conditions. Now, things like heart disease, which he doesn't have, but he has respiratory illness.
Patrick's dentist, Dr. Bilodeau, explains.
It is something that, people who have any immunocompromised situation, such as him, he has quite a serious situation there, he should have excellent care of his teeth.
Dental complications limiting overall health isn't unusual, according to Dr. James McCocus, a Cree physician in Alberta.
A lot of the times, children and adults have dental complications which can lead to long-term health problems like cardiovascular problems.
Health Canada's own documents say that oral health contributes to overall health. In NIHB's annual report from 2014 and 2015, they say First Nations and Inuit experience a higher rate of dental disease, such as periodontal disease and caries, compared to other Canadians. Poor oral health can contribute to a greater incidence and severity of other medical conditions, such as diabetes, respiratory illness, and cardiovascular diseases. But in that same period, dental coverage was just $207 million. In many cases, the delays and refusal to cover cost professionals time and money.
Dental health is an area is a challenging area in health because of the limitations that are placed by the NIHB program on the payment of dental practitioners and dental hygienists. So they don't get compensated in a timely fashion, and so people can't go to just any dentist because they will reject their NIHB coverage.
Dr. Bilodeau also expresses some frustration with the program.
Sometimes you submit something and you just never get a response back. And then you have to go, oh, geez, I have to do this. And if it takes you 2 or 3 months to get to the point that you're going to be providing treatment, that's going to be a big barrier to care. So it's not just the practitioner's time, and that's very frustrating because you don't go to school to become a paperwork person. You want to help people.
It isn't always about follow-up care. It's also about patient advocacy. Some patients don't even know they can appeal a decision.
No one had ever told me about the appeals process.
Doctors often have to step up and advocate for patients. It costs time and could potentially cause more harm to the patient's health.
A lot of the advocacy that we do with NIHB is directly from the physician perspective, and sometimes we can delegate that to allied health professionals or assistants, which means that they're taking time from looking after other patients.
Dr. Makokis suggests documenting the refusal on patients' charts.
We have to advocate strongly for our patients to have the medication or medical supply or service covered. And what Indigenous physicians have had to do is, when we're calling them, ask who their name is and say that we will document it in the chart that they are refusing care.
Dr. McCollum says appeal is every patient's right.
Every patient has the right to an appeal, and they decide whether or not they want to appeal, and then I'll help them write the letter.
NIHB has an appeals process on their website, but that's not helpful for patients in need. Many don't even have internet, like in remote communities.
There we go.
Lee says the bands are asked to fill in where NIHB is failing.
Well, you know what? They tell us to go to the band for everything. He needs a nebulizer machine to dispense his meds at home. You use it, 4 or 5 times a day? You know. Indian Health used to pay for that. Well, he needed a new machine because the compressor went on his. And we found out from Metagas that Indian Health tells them to tell the client to go to the band.
Patrick says he can't always get help from the band because he doesn't live there.
My band, they can't help me. Their hands are tied, my band. They could only help people on the reserve.
For Patrick, his home community of Fort Chipewyan offers additional challenges to its remoteness.
I had to be flown out one time. It took 2 hours, 2.5 hours. They call a plane in. You know, I was pretty lucky. I came out alive.
Patrick isn't convinced Ottawa does all they can.
You guys are killing me, you white bureaucracies. And you say, oh, we're helping people, Native people here. We're throwing a lot of money through, you know. That's a bunch of bullshit. Something's wrong with you guys, your mathematics. Or you're just cheap.
So what can we expect in a remote community? Lee says Patrick could get more support if he moved, but once he had to be flown out. After the break, we'll go to Barren Lands First Nation to hear about dentistry and healthcare in northern Manitoba. If Patrick's life is at risk in the city, what can Indigenous people expect in remote locations? We fly north with Dr. Mary Jane McCollum to find out. We're in Brochet, Manitoba, and Barren Lands First Nation. It's one community that's on both reserve and non-reserve. Health professionals fly in here. Dr. Mary Jane McCollum calls it home, but she lives in Winnipeg.
I'm from the Barren Lands First Nation. I went to residential school, so I was removed from here when I was 5.
Her qualifications are extensive.
So I was an assistant, a dental nurse, therapist, a dentist. I was also an assistant prof in Churchill and then at the main campus. And then I was a dental officer for Manitoba for 4 years.
The north is where she wants to be.
I've always wanted to work on reserves, and that's where my heart is. And I didn't consider private practice because I feel that dental disease is a public health issue and that it isn't a business.
For a long time, she felt the entrepreneurial model wasn't right for First Nations.
You drill, fill, and they're gone. And about 15 to 20 years ago, I realized that was not appropriate for our people.
Dr. McCollum says dental health is affected by social determinants.
Did the child have a good sleep? Was there violence in the home? last night? Was there drinking? Did they eat this morning? You know, and were they abused? Whether it's physical, mental, sexual, and that's what I think of the patients when they come in. So if you have that, and you're homeless, you're living, your family's living with the parents, how can I say, brush your teeth?
I've heard it said many times that the social determinants of health can't be solved in this generation. You know, what we're literally saying is that everyone who's living right now will need to die if we don't solve it this generation.
But one simple change in approach can get things moving in the right direction.
You know, we know that access makes a difference. It's just making the choice of whether or not we're going to introduce it.
So, access to care varies. Some professionals avoid on-reserve care.
Recruitment of adequate health professionals to Indigenous communities is a huge issue because of the barriers that exist with lack of equipment, lack of support, lack of supplies, having to advocate to this extent and level.
Not a lot of dentists want to work on First Nations. It's the bureaucratic hassles, and it's the payment, because they pay less.
Compensation is a concern for both those on and off reserve.
Insurance companies pay more than Health Canada. So it's a decrease in pay. So with the hassles, the decrease in pay, people say they don't need that.
This health center hasn't seen a doctor in over 2 months. The day after APTN Investigates arrived, a doctor flew into the community. John Clark, chief of Barrenlands First Nation, explains.
Supposed to get a doctor in once a week. I think it's been 11 weeks today. And I think we finally got a doctor today, but I've asked one person and they think the doctor came in. But 10 weeks in a row we had no doctor.
Chief Clark just met with other northern chiefs and health authorities.
We met with Health Canada, the Northern Regional Health Authority, to see what's happening, and like they're sending me updates now, but it's like updates are no good when there's still no service.
Bringing in professionals can be challenging, but what about getting a patient out? You can't get a road ambulance if there's no road. You can't get an air ambulance in bad weather.
I think there's certain levels of care that can't be provided unless you have economies of scale. You know, it's difficult to provide, you know, cardiac surgery to a population of 300.
Dr. McCollum feels that Indigenous communities are left out.
There is very little respect, or none, of the governance system that exists in the community.
This is something Patrick recalls from residential school.
To bring Native people coming into residential school, like the chiefs or the counselors or the parents, that didn't happen. They had no say.
It's a historical legacy that continues to this day.
A lot of the programs are being run the way Health Canada has set them up. So this has nothing to do with self-determination. It's a mini model of the pre-existing system, which didn't work.
Until we get to the point where our communities are empowered to kind of map out their own systems, we won't be able to get targeted, we won't be able to get efficient, we won't be able to really build up our northern health systems.
Lee Deranger claims the bureaucracy doesn't even know what happens with patients under its own care.
I was quite shocked that they had no idea. And I asked why, and they said, well, we don't see that stuff, we only see the dental.
So, she offered to provide more information because she felt like money was an issue.
And I offered to go and get other documentation. What documentation would they like? And they assured me they didn't want any documentation. And so it looked to me like they want to make the decisions based solely on a monetary model rather than on a delivery of health services when there's complicating health issues.
Dr. McCollum also sees a system more concerned with saving money than saving lives.
I believe that a lot of this is done for cost containment instead of appropriate health care.
And what that means is that the band or the First Nation or the community has to take money from another already underfunded program.
So we don't have a team concept on most of the reserves. The doctors are taking care of their medical. The dentist comes in, does their dentistry. The nurses are doing their care.
Some say racism gets in the way.
This health issue between Indigenous people and the government, well, one side's Native, eh? The other side's white.
You see it a lot in the communities, and people complain, and sometimes it gets to the chief's level, but a lot of times people are afraid of speaking up.
And it's supposed to be equal to Canadian healthcare.
It's not equal. It's not equal. It seems like the further north, the harsher it gets.
Is it meant to be the same?
It's not designed to be the same sort of health system. You know, in mainstream systems, like here in Alberta or in Saskatchewan or other places in the country, there's a very defined function for what the health system provides and doesn't provide.
Dr. LaFontaine says mainstream systems in crisis get what they need without question. But a First Nation community is required to do much more.
But instead of just providing those programs to everyone, we often force our First Nation communities to go through a process where they have to justify that they need the program, and then they have to work through a process where it gets funded. In the mainstream healthcare system, it doesn't happen in the same way. Those are questions that our communities don't ask because they don't know that that's what everyone else gets. But I think you're starting to see communities realize what everyone else has and realize that in a lot of ways our treaty promises just aren't being followed through on.
Some health professionals say not enough change has happened.
So when you look at all these mini models that are being put in place by First Nations communities and individuals, they didn't work. Why are we copying them? Why are we doing the same thing over and over again?
That what we're doing isn't working. And we can either choose to move in a completely different direction, or we can choose to continue to support a system that I think doesn't provide outcomes that people are happy with, and not just communities, but also government as well.
If we don't look at delivering healthcare in a different way, we're going to have more people end up being very vulnerable.
Who's going to fix it?
Are we getting equal and equitable healthcare? Is it timely and accessible? Are healthcare professionals collaborating effectively? Many say no. If healthcare is a treaty right and a right of all Canadians, why is it so elusive for Status Indians? Next week on APTN Investigates, Killer Pain, the opioid crisis in Canada.
There is a person dying every 6 hours.
I can only take fentanyl or carfentanil, feel my stuff, I can feel the rush.